All right. Good morning, everybody. Dr. Arafich here from Vet Triage. It is October 18th, 8:50 a.m. Pacific time. We are starting a new journal today from JAVMA. This is January 15, 2016, volume 248, number 2. And we're starting off with the very first article, which is what is your diagnosis? Let's get into it. So a 5-year-old female spayed Maltese was evaluated for vomiting and not eating for 3 days. They found swelling in the left inguinal region. So the inguinal region is the groin area. And the swelling had been there for a few months and getting worse over those 3 months. On physical exam, or on presentation rather, they performed blood work, which showed a high PCV, which is packed cell volume. Typically with a high packed cell volume, we're really looking at 2 causes, although there could be others, but 2 common ones. One is hypovolemia or dehydration. The second is going to be a cardiovascular condition where the body has a relative hypoxemia, so low oxygen levels, and then starts to pump up red blood cells from the bone marrow to try and make up for it. When in reality, the body does not actually have low blood mass. It's purely a circulation problem. So polycythemia is the latter cause that I mentioned. Hemoconcentration is the first. Total solids concentration of 9, which is also elevated. Total solids is also total protein, and it's whatever is in the blood that is contributing to protein, like albumin, for example. But there's a couple of reasons for having high protein in general. First is hypovolemia again, so that's hemoconcentration. The second is inflammation. The third is cancer, and the fourth is going to be infection. All those things can cause a high protein amount. They found that lactate was high. Hyperlactatemia most often is caused from dehydration or hypovolemia, but it could be from muscle damage and other diseases. And then glucose was high. Hyperglycemia can be related to stress. It can be related to an endocrinopathy or a hormone issue like diabetes mellitus and so forth. And so if you pay attention to all those differentials, hypovolemia or dehydration is a common theme amongst all those abnormalities. So chances are those blood work abnormalities are from hypovolemia or dehydration, which makes sense because the Maltese had been vomiting and not eating. So they collected abdominal radiographs, which you see here, 2-view plane radiographs. Now, right off the bat, I'm going to say that ideally you perform 3-view abdominal radiographs, especially if something like foreign body is on your list of differential diagnoses. And the reason for that is because you could have one view that actually captures the foreign body, let's say, and the other 2 views missed it. So I recommend 3-view orthogonal plane radiographs for your abdominal workups, hands down, which they did not do here. And so that's a criticism that I have. So then here is the abnormalities in the on the radiographs. You can see there in A, they're pointing to with the arrows, they're pointing to the soft tissue swelling in the left inguinal region. And then the asterisks are showing gas-filled small intestinal loops that are dilated beyond what we deem as normal. We'll go into that. The ventrodorsal view, which is part B, has the same findings there: intestinal loop dilatation with gas and the soft tissue swelling in the left inguinal region. Radiographs show multiple segments of small intestine, moderately distended. Now, the normal intestine, and I rarely do this, but you're supposed to compare the luminal diameter of the small intestine to the height of the vertebral body of L5. And the normal reference, the intestine should be less than 1.6 to 2 times the height of the vertebral body of L5. In this case, they measured it 3.3 times the height of L5 vertebral body, which means they were distended. Then they describe the inguinal swelling as an ovoid, smoothly marginated, heterogeneous, soft tissue and fat opaque mass measuring 5 by 3 by 3 centimeters. So their primary rule out was small intestinal mechanical obstruction, could be due to foreign body, adhesions, neoplasia, intussusception, herniation with incarceration. And then for differential diagnoses for the inguinal swelling, could be inguinal hernia, soft tissue neoplasm, steatitis, abscess, and hematoma. So let's go over a few things there. Neoplasia is cancer, and intussusception is when one segment of intestine telescopes into the other. And then herniation with incarceration means that the intestinal loops have gone into the hernia, and because the hernia was trapping and strangulating the intestines, you end up with a loss of blood flow to the intestine and loss of viability of the small intestinal tract. Steatitis is inflammation of the fat. Abscess is a pocket of infection and inflammation. Hematoma is like a blood blister. It's a blood-filled cavity. Okay, so abdominal ultrasonography was performed, and they found that there were distended small intestinal tracts that could be followed into the hyperechoic mass of the left inguinal region. So a small intestinal incarceration and steatitis within a left inguinal hernia was the diagnosis. They performed abdominal surgery, so exploratory laparotomy, also known as a coleotomy. They had to resect and anastomose a segment of jejunum. They also removed a portion of the omentum that was stuck in the hernia, so that's a partial omentectomy. The hernia was partially closed while still allowing passage of the normal inguinal structures. So those normal structures are the genitofemoral nerve, the external pudendal artery and vein, and the superficial inguinal efferent lymph vessels. 3 weeks after, the inguinal hernia recurred. The patient was vomiting. They did another surgery. No bowel was incarcerated this time, but they were able to close their inguinal hernia even further. So now they go into the comments. Inguinal hernias occur as a peritoneal evagination through the internal and external inguinal rings, which are formed by the internal abdominal oblique and rectus abdominis muscles, the inguinal ligament, and the aponeurosis of the external abdominal oblique muscle. So let's go into those terms. Inguinal hernias occur as a peritoneal evagination. So the abdominal cavity, the peritoneal cavity, is lined with a thin layer of mesothelial cells called the peritoneum. And during embryogenesis, when the embryo is being formed, the peritoneum evaginates in the groin area to form what will be the inguinal rings. There are 2 inguinal rings, internal and external. That doesn't mean that one's outside the body. They're both in the body, but internal is facing the abdominal cavity, the perineal cavity. The external is facing the inguinal canal, or rather where those structures are going to pass through the inguinal rings. And that the boundaries of the inguinal canal, so that space between the internal and external inguinal rings, as well as the lining of the peritoneum, that boundary of that canal is formed by the internal abdominal oblique muscle, the rectus abdominis muscle, the inguinal ligament, and aponeurosis of the external abdominal oblique. Aponeurosis is the non-muscular fibrous tissue that extends from a muscle and goes to another structure. So those are the boundaries of the inguinal canal. Contents within the hernia frequently include fat or omentum. They also may include the small or large intestines, urinary bladder, or in females, the uterus. Additional radiographic signs include the absence or displacement of organs that are normally present in the caudal aspect of the abdomen, such as urinary bladder or intestine. And this may be better delineated by performing radiographic positive contrast study. So radiographic positive contrast study is when you administer a contrast medium into the patient. It can be done intravenously, it can be done orally, rectally, urinary tract. But the point is to try and outline abdominal organs or blood flow in these dogs. And whether you perform that is up to you. Now, most folks these days have abandoned that for the benefit of abdominal ultrasound. Abdominal ultrasound is much more simple to perform if you have an experienced ultrasonographer. It's not invasive. The patient doesn't have to be anesthetized or sedated unless they're being fractious or something. But you can, for this case, if you wanted to figure out the vomiting, you could have given the patient barium to swallow. There's a chance for vomiting up the barium as well. And if they inhale that, that's going to cause a severe pneumonitis, aspiration pneumonia. Or if you're trying to assess what's in the inguinal hernia, like urinary bladder, then you could pass a urinary catheter. This dog is a female. They're a bit tougher to catheterize, but you could do that and perform a positive contrast urethrogram or a cystourethrogram to outline the urethra and the urinary bladder and see if they're entrapped. So those are two different options. You could theoretically inject contrast into the anus and outline the large colon as well to look for a large colonic entrapment. Intravenous contrast administration probably won't help you with this case, but anyway, just to be thorough. But ultrasound is the minimally invasive way of doing it. And others believe that if you perform contrast into the gastrointestinal tract and then have to go to surgery, if there's any spillage from surgery, that contrast medium can cause peritonitis, which is inflammation of the peritoneum. However, I would also argue, though, that when we perform gastrointestinal surgery, you're trying to avoid leakage anyway. So I'm not really sure it's a viable concern anymore. However, what may be a concern is if you administer contrast material in the gastrointestinal tract and then decide that you didn't get your answer and then follow up the abdominal ultrasound, the contrast study could affect the abdominal ultrasound, make it tougher for the ultrasonographer to diagnose anything. So if you have abdominal ultrasound and you're debating about positive contrast or positive contrast study, I would recommend not doing it. Do the ultrasound first. Then if you don't get your answer, do the contrast study. And of course, CT scan, MRI, those are also options, but those aren't the most realistic or readily available. Conventional inguinal herniorrhaphy, which is the surgery that you'd repair this with, typically consists of suture closure of the external inguinal ring. Larger traumatic or recurrent defects that may be more complex and require the use of synthetic mesh or a muscular flap like the cranial sartorius, which is a muscle in the hip. For tension-free reconstruction, postoperative complications with herniorrhaphy include incisional infection, dehiscence, peritonitis, neurovascular injury, or hernia recurrence. And that's a pretty straightforward case. So that's a small intestinal incarceration and an inguinal hernia in a dog. Thanks everybody for watching, and those who watch the playback. We'll be back tomorrow for another one. Take care. Bye, 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 bye.